Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. I'm not a cardiologist. I'm still a student at present. Whatever I've gathered from internet, I'm sharing with you. Today we'll be talking on once you clinically suspect a person is having a congestive heart failure, how you approach. So it is approach to congestive heart failure. So once you suspect a person to have a congestive heart failure, and that suspicion is by clinical history and physical examination. In clinical history, usually the person who comes to you with dyspnea, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and on examination, say you get edema, JVP elevated, hepatosplenomegaly, ascites, basal crackles. Person is also having, say, cough with bloodstained frothy sputum, etc. Cyanosis, central cyanosis, all that will favor congestive heart failure. Now, if the person has got limitation to his functional activity, depending upon that we grade them according to NYHA classification from grade 1 to grade 4, and according to ACC we grade from A, B, C, D. So you grade them according to that history. We also take a history of previous cardiac disease regarding risk factors, any exacerbating factors. We look for comorbid condition like diabetes, hypertension, anxiety, person who is taking steroids or NSAID, etc. Contraceptive pills, all those histories taken. And on physical examination, we add weight. Any weight gain is in favor of fluid retention. We look at the volume status. We examine cardiovascular system thoroughly, and we look for any murmur. We look for S3 sound, third heart sound. You look for cardiomegaly on clinical examination, and also in a lung you look for basal crackles. In abdomen, hepatosplenomegaly, ascites, and HJR, hepatojugular reflux. And also we examine in a vital data pulse, blood pressure together. Now suppose by clinical good history, good physical examination is in favor of congestive heart failure. So we call straightforward positive. Now once it is positive, we go for certain investigations. Say we go for X-ray chest. In X-ray chest you see cardiomegaly, mild pulmonary congestion. In a severe variety you can get a butterfly appearance, pulmonary plethora. We call curly A line, curly B line here, curly A line here, and curly C line in the center. Bilateral pleural effusion, etc. you can see in a chest X-ray. In an ECG, you can demonstrate cardiac arrhythmia, ischemic changes, ventricular hypertrophy like LVH, RVH, etc. And to confirm, sometime in some cases when there is a doubt, you can go for an BNP, or we call it the end-terminal BNP. The elevation of BNP or end-terminal BNP is very specific for congestive heart failure. As far as the laboratory parameter is concerned, CBC, electrolytes, renal function test, urine analysis, ruling out diabetes, thyroid function, because thyroid disorder is also responsible for congestive heart failure, precipitation of congestive heart failure. If this investigation is also in favor of congestive heart failure, it is very easy. Now we go for what we call as assessment of ventricular function by doing a good echo. A good echo will give you lot of answers regarding LA, RA, RV, means chamber enlargement, chamber volume and diastolic volume of LV, RV, ejection fractions, regional wall abnormality suggesting ischemic heart disease, cardiomegaly. It can also give you an idea regarding a pericardial conditions, because pericardial condition can mimic like congestive heart failure, like constrictive pericarditis, restrictive pericarditis, or even in case of a pericardial tamponade, etc., which can mimic identical like congestive heart failure. So echo gives lot of answer. Even it gives an answer regarding a thrombus, infective endocarditis, pulmonary hypertension, how severe, that also you can identify by doing echo along with Doppler. All these investigations are very, very useful. And once you do a good function test by echo, depending upon the ejection fraction, we classify them into three groups. One, normal, where ejection fraction is more than 60. The second group, systolic dysfunction, where ejection fraction is equal to or less than 40. And if ejection fraction is reduced, that we call systolic dysfunction, and short form we write down as heart failure, HF. R is reduced ejection fraction, and R is written as a small alphabet. While if the ejection fraction is preserved, we write down heart failure P, preserved ejection fraction, means ejection fraction is equal to 60. Now suppose if the ejection fraction is reduced, it is systolic dysfunction. If ejection fraction is preserved, we call it a diastolic dysfunction. Again, in this diastolic, between 41 to 49, it is called as minimal reduce or marginal reduce, marginally preserved ejection fraction. And that is a variety which is between diastolic and systolic dysfunction. Laboratory parameter wise, we try to do some of the investigation, particularly thyroid, diabetes, renal function, liver function test, etc., and even electrolyte imbalance. So that can affect congestive heart failure. In case you can go for radionucleotide imagination, cardiac catheterization, right side and left side, to rule out right heart failure, left heart failure. Then cardiopulmonary exercise testing, you can go for MRI, CT, myocardial biopsy to rule out myocarditis, cardiomyopathy, and even you can combine angio with CT to rule out ischemic heart disease, CT angio or MRI angio, etc. These are all the tests you can go for. And after that you can confirm the diagnosis that what variety, whether it is mild, moderate, severe, it is diastolic, systolic with minimally reduced ejection fraction, or according to NYHA classification or ACC classification ABCD, or according to NYHA grade 1 to grade 4. So you have to put into that groups and you will have to divide that. So same thing is mentioned here. So first, by good history and good physical examination and ECG, you try to confirm the diagnosis of congestive heart failure, and also you can identify the stages depending upon the history, a good history and good examination. Then you can confirm further by doing N-terminal BNP if it is more than 125, or BNP equal to 35, almost it rules out, there is no possibility. But if N-terminal BNP is elevated, or BNP is elevated, it straightforward goes in favor of congestive heart failure. And by echo, you can further separate out into those different groups. So when you do an BNP and terminal BNP, if it is 125 or BNP is 35, then straightforward it excludes heart failure. Exclusion, it exclude heart failure. But if N terminal pro BNP is 300 or more than 300, straightforward it goes in favor of an acute decompensated heart failure, or BNP more than 100 is straightforward in favor of acute decompensated heart failure. So by doing a good BNP, you will be able to identify and differentiate a heart failure is present or not. It is a good investigation, and echo will tell you regarding the type of heart failure, whether it is with reduced ejection fraction or it is with preserved ejection fraction. So these are the conditions where BNP is elevated. These are all the conditions where BNP can be elevated: heart failure, atrial fibrillation, acute coronary syndrome, pulmonary embolism, left ventricular hypertrophy, hypertrophic cardiomyopathy. These are we call as a myocarditis, perimyocarditis, after electric cardioversion, defibrillation in congenital heart disease following a cardiac surgery, pulmonary hypertension in a non-cardiac condition like kidney failure, aging, stroke, subarachnoid hemorrhage, cirrhosis, COPD, anemia, severe sepsis, ketoacidosis, thyrotoxicosis, paraneoplastic syndrome. So there are some of the non-cardiac condition also BNP will be elevated. But you have to pay attention to the figure and always rule out renal failure. So in presence of renal failure, BNP may be abnormal. So then it becomes difficult. But if renal failure is not there, you go for a particular figure. So if N terminal BNP more than 300 or plain BNP more than 100 goes in favor of congestive heart failure. Now there are some investigations which are very useful. Say like EKG gives you an idea regarding cardiac arrhythmia, ischemic heart disease, LVH, RVH, etc. Chest X-ray, cardiomegaly, RVLV, LARA, pulmonary congestion, pulmonary plethora, butterfly appearance, curly A line, curly B lines, all goes in favor of congestive heart failure. Echo is the best way. Echo gives you lot of answers, and it will give you the functional part of ventricles. So it will tell you regarding the ejection fraction. It will give you an idea regarding a left ventricular and diastolic volume, right ventricular and diastolic volume, etc. You can identify, and you can also identify systolic, diastolic, preserved function, reduced function, and mid-range functions, etc. If you want to identify whether it is an ischemic heart disease or not, then we go for a cardiac catheterization and you go for angio, where you can combine with CT or MRI. You can go for a pressure studies by doing a right heart catheterization or a left heart catheterization. In right heart, you can go for RA, RV and pulmonary artery pressures. In a left heart catheterization, LA, LV, pulmonary venous pressure, pulmonary capillary wedge pressure, etc. you can identify. As far as the blood report is concerned, renal function test by blood urea creatinine, urine routine examination, ABG to find out the acidosis, alkalosis, electrolyte imbalance, liver function test to identify the effect of congestive heart failure on liver. Also, you go for thyroid function test to rule out thyroid disorders which can precipitate. And we have already mentioned regarding a BNP, brain natriuretic peptide, or N-terminal pro-BNP. because those levels are very important in absence of renal failure. Very, very useful to confirm, but clinically if you are sure, there is no use of doing BNP. So patient history, physical examination, diagnostic study like ECG. Ideally, electrocardiogram does not give you ejection fraction. It will be echo, radionucleotide study, MRI, CT scan, cardiac catheterization with angiography. Biopsy is needed only if you want to rule out cardiomyopathy, storage disorders, etc., which is very common in diastolic dysfunction. So physical examination, good medical history is the first part. Then as far as investigation is concerned, X-ray chest and echo comes most important part. Lung function test is useful to rule out COR-PULMONALE. ECG gives you an idea regarding QT intervals, Q wave, ischemic changes, cardiac arrhythmias, atrial flutter fibrillations, etc., which can be a precipitating factor for congestive heart failure. And as far as laboratory parameters, we already mentioned BNP becomes very useful, and particularly if possible N-terminal pro-BNP is most useful. So these are all the investigations which are necessary. And after all this medical history, physical examination, laboratory parameters, X-ray, ECG, echo, etc., you should be able to differentiate between acute and chronic, systolic, diastolic, whether it is a pure right ventricular failure or it is a LVF or it is LVF with CCF, we call congestive heart failure. You should be able to stage it according to ACC, ABCD or NYHA 1 to 4. You try to identify precipitating factors and exact etiology for congestive heart failure, whether it is ischemic, acute MI or non-ischemic groups, etc., should be easily answered. So this is ECG investigation, which gives you idea regarding ischemia, previous myocardial infarction, recent infarct, cardiac arrhythmias, ventricular hypertrophies, etc. So dysrhythmia, tachycardia, atrial flutter fibrillation, bundle branch block, all gives you a good idea. Echocardiogram will give you a lot of ideas regarding regional wall, systolic, diastolic dysfunction, myopathy, dilated cardiomyopathy, constrictive cardiomyopathy, cardiac tamponade. It can also give you an idea regarding infective endocarditis, thrombus formation, valvular heart disease, which type of valvular, how severe, ventricular functions, ejection fractions. You can go for even a pressure studies. It can give you regarding pulmonary hypertension, pulmonary venous pressure, wage pressure, all those ideas it can give you. And you can classify according to ACC classification, that is ABCD, A for high risk groups, B for asymptomatic heart failure, C for symptomatic heart failure, and D for refractory failures. So you can put them into that particular groups. X-ray chest gives you idea regarding cardiomegaly, curly A line, curly B line, pulmonary congestions, pleural effusion, bilateral pleural effusion. These are curly A line, red arrow shows you curly A line, and at the base we call curly B lines. You get cardiomegaly, you can have a severe pulmonary congestion that is going in favor of pulmonary edema. Sometimes you can, even on a plain X-ray, you can see a pacemaker which can be for either AV, we call AV pacemaker, or atrial pacing, AV pacing, or we call biventricular pacing can be also there. Depending upon that, you can identify even on an X-ray. Sequential pacing can be done, that is we call it an AV pacing, and that is very frequently done in a person with a severe congestive heart failure. It is one of the treatment, or sometimes you can have even ICD, etc. Because You can use a pacemaker. You can use ICD in a treatment of congestive heart failure. So that may be already present, which indicates the person was already having a congestive heart failure. So these are the X-rays which gives you an idea regarding curly A line, curly B line, cardiomegaly, hydrothorax, interstitial fluids, horizontal fluids, or fissure, fluid in fissure, etc. can be identified. And depending upon the X-ray finding, you can put them into stage 1, stage 2, stage 3. So stage 1 will be redistribution congestive heart failure. Stage 2 will show you interstitial edema. And in stage 3, you will have a curly A line, curly B line, peribronchial cuffing, then thickening or fluid in the fissure. And in stage 3, you will start getting alveolar edema. You will have a bat wing appearance, or we call butterfly appearance, bilateral pleural effusions. There is another very simple test we call as a 6-minute walking test. While doing a 6-minute walk test, if the person is able to walk for approximately, we say 500 meters, we usually call that as a mild cardiac dysfunction. If it is between 150 to 400, roughly we say 150 to 400, we call moderate. And if it is less than 150, the person gets fatigue or tired, or he starts getting dyspnea, then we call that as serious cardiac dysfunction. A very simple way to identify, which does not require any investigative procedures. It is called 6-minute walking test. So if a person is able to walk for 500 meters, it is mild. More than 150 but less than 500, we call as moderate. And less than 150 meter, person gets symptomatic, it is serious cardiac dysfunction. BNP, pro-BNP I already mentioned. CBC count does not help you much, but anemia can be a precipitating factor. And if you get a leukocytosis, it goes in favor of infective endocarditis or infective pathophysiology, which is responsible. In urine analysis, hematuria, proteinuria goes in favor of infective endocarditis. Serum electrolyte is useful because some of the electrolytes, particularly potassium, can produce serious cardiac arrhythmias and can precipitate. Blood urea creatinine elevation, that is renal dysfunctions, and in presence of renal dysfunction, BNP does not hold true. So if BNP is less than 100, almost it rules out congestive heart failure, and BNP more than 500, 100% in favor of congestive heart failure. But you have to first rule out renal. Diabetes should be ruled out. Liver function test should be done, because in congestive hepatomegaly, liver function will be little abnormal. Cardiac enzymes will be useful, particularly CPKMB and troponin I, which will be very useful to rule out ischemic, non-ischemic. ABG is useful to rule out hypoxia, hypercapnia, acidosis, and electrolyte imbalance. Hematocrit, if increase in hematocrit, good number of time it is in favor of a COR-PULMONALE, chronic COR-PULMONALE, particularly chronic hypoxia, increase hemoglobin concentration, increase erythrocyte count, all three goes in favor of polycythemia. Electrolyte imbalance like hyponatremia, hypokalemia is useful. Increase ANP, BNP, we have already mentioned, are useful to rule out congestive heart failure. Arterial blood gas study, we have already mentioned. These are some of the biomarkers which will be useful, and usually they are more abnormal in grade 3 and grade 4 variety. They are definitely abnormal. And also it is useful to rule out, we call as a COR-PULMONALE. By and large, if BNP is less than 100, straightforward, there is no possibility of a heart failure. Or if you do an N-terminal pro-BNP, then less than 300 rules out. But BNP more than 500 and N-terminal more than 1000, 100% in favor of heart failure. The sensitivity rate is very, very high. But at the same time, you should keep it in mind there are non-cardiac conditions which can also elevate the BNP, like advancing age, anemia, renal failure, COPD, obstructive sleep apnea, pulmonary hypertension, critically ill patient, septicemia, severe burns, etc. Cancer therapy, congestive, cardiomyopathy, cardiac tamponade, obesity, etc. can also have increase. And some of the conditions in cardiac, there are a lot of cardiac conditions which can have an elevated BNP apart from congestive heart failure, acute coronary syndromes, LVH, valvular heart disease, pericardial disease, atrial flutter fibrillations, myocarditis, post-cardiac surgery, cardioversion. You should keep all these things in your mind. Nuclear imaginations is very rarely required. It is usually required in an end stage variety to find out the severity of the damage to the myocardium. Angiography is mainly required to rule out ischemic and non-ischemic groups. Cardiac catheterization, right heart and left heart, is to find out RV and LV functions and pressure studies, and to put them into systolic and diastolic dysfunction groups. Certain other procedures like central venous pressures, pulmonary artery catheterization and pulmonary artery pressure studies. 6-minute walking test is also useful. Also, you can go for a pulmonary function test, polysomnography to rule out obstructive sleep apnea, Holter monitoring to rule out cardiac arrhythmias, etc. By and large, you don't require any differential diagnosis if you are clinically sure, and some of the laboratory parameters and ECG, echo gives you a good answer. ECG, X-ray, chest and echo gives you almost answer. But you should be able to differentiate congestive cardiac failure from COR-PULMONALE with congestive cardiac failure, edema because of other condition like hypoproteinemia, venous edema, whether it is an right ventricular failure, pure right ventricular failure, or left ventricular failure, or it is congestive heart failure. There are many other conditions for pulmonary edema apart from left ventricular failure. You should be able to differentiate, and there are good number of conditions which produces pulmonary edema, like re-expansion edema, high altitude we call as a HAPE, organophosphorus poisoning, ARDS we call as a non-cardiogenic pulmonary edema, drowning. All these conditions you should keep it in your mind. Management part becomes very important. One we call as a symptomatic management, treatment of the basic cause, treatment of precipitating factor, and diet regulation. And then person should have a regular follow-up. You can give prophylactic antibiotic, particularly in a person with valvular heart disease, to reduce chances of infective endocarditis. Vaccination should be done in a COPD old individual, particularly for flu and pneumococcal. And then you can go for what we call as a surgical intervention in case of a valvular heart disease, like valve repair, valvuloplasty. In stage 3 and 4, you might require particularly in stage 4, or we call it the resistant congestive heart failure, counterpulsation. You might require what we call as ICD or CRT, or you might require a support like LVAD, left ventricular assisted device, Impella, or you can go for a heart transplant, stem cell transplant. You can use pacemaker. There are reconstructive surgery, strengthening of right ventricle, left ventricle, etc. There are a lot of surgical intervention which can be done. We'll be going one by one. First is relief of congestion by giving diuretics, inotropic drugs, vasodilators. You can reduce the progression of what we call as remodeling and reverse the remodeling by using ACE inhibitor, beta blocker and spironolactone. So ACE inhibitor, beta blocker and spironolactone and diuretic becomes the prime choice in treatment of congestive heart failure. Usually this is the common word which is being utilized: unload fast or unload me. U for upright position, N for nitrate, L for Lasix, that is diuretic, O for oxygen, A for ACE inhibitor and digoxin. So this is called unload. And fast means fluid restriction. You decrease the afterload, sodium restriction, and certain tests, diagnostic tests like ABG, potassium level, BNP level, etc. So this is that particular word. And when you use the unload, means upright position, nitroglycerin, Lasix, oxygen, A for salbutamol or we call bronchodilator, D for dobutamine, that is vasopressor, M for morphine, and E for electric shock in case of certain cardiac arrhythmia, particularly atrial flutter fibrillations. This is just to remember, but by and large we always say there are something which are very important, we call as a lifestyle modification. Position, rest becomes the prime thing, and in diet, sodium restriction, restriction of NSAID, salt, we call glucocorticoids, all this should be restricted. Use of inotropic drugs like digoxin. Now there is also use of amiodarone or milrinone. Dobutamide is by and large utilized for inotropic effect to increase the cardiac output. Also it is being utilized to increase the blood pressure. Diuretic is utilized mainly to reduce the volume overload, or we call as a preload. Vasodilators to reduce the afterload. That is, you can use ACE inhibitor, hydralazine, nitrates. Beta blockers are mainly for protection in an ischemic heart disease and also to reverse the progression or what we call as a remodeling. ACE inhibitor is also mainly utilized for that purpose. Beta blocker, ACE inhibitors and spironolactone mainly for reversing the progression. So already we have mentioned all these things. Now there is an use of what we call as ARNI, that is angiotensin receptor neprilysin inhibitors, which will have a beneficial effects by decreasing the neurohormonal activity. It decreases the vasomotor tone. It decreases the cardiac fibrosis and hypertrophy. So there is a reversal of remodeling part, and it is also natriuretic. So it reduces the sodium retention. All these are beneficial effect of ARNI, and ARNI is a combination of ACE inhibitor with sacubitril. So this is a very good drug and very useful. And while using that particular drug, usually starting dose is 24-26 combination of those two compounds, and gradually you increase to 49-51, and that maximum dose is twice daily. So this comes to 100 milligram twice daily. Usually when you are starting with that, you will have to stop other ACE inhibitor or ARB, whatever you are using, and switch over to this particular compound. Maximum you can go up to 200 milligram twice daily. So, but while using this particular dose, you should keep a watch on potassium, as well as you should keep a watch on volume levels and other parameters. And very useful compound. Ivabradine is mainly to reduce your heart rate. So while giving all the other treatment, if still heart rate is high, you can use ivabradine. Maximum dose you can go up to 5 milligram BD. But while using this, in addition to beta blocker, highest dose of beta blocker is utilized, and still if the resting heart rate is not maintained at 70, you can add ivabradine. So ivabradine is very useful to reduce the heart rate and improve the survival. So ivabradine maximum you can go for 5 milligram twice daily, and target heart rate should be less than 60 but not less than 50. So you can utilize. Some person utilizes go up to 7.5 twice daily, but by and large 5 milligram BD is adequate enough. Don't go below 50 pulse rate. So all these drugs, drug, right dose, right patient, and after using that, look at the follow-up, look at the monitoring part, and that is how you choose. As far as the lifestyle modification is concerned, stop smoking, reduce your weight, avoid alcohol, avoid NSAID, avoid steroids, regular exercise, calculated exercise, and take medication regularly. So weight reduction, input output chart, low sodium diet, fluid restriction is a prime thing. There are some of the materials which are doing harm, there are some material which are beneficial. Say like lemon juice is beneficial. Then these are some of the seeds, cucurbitacin seeds, they are vasodilator. Garlic is believed to be good for hyperlipidemia and also in a case of hypertension. So garlic consumption is useful. Coconut water is rich in potassium, magnesium and vitamin C, and potassium is beneficial in blood pressure as well as in cardiac functions. Even they say that honey and these seeds, fenugreek seeds, are also beneficial in hypertension. So these are all the material which are beneficial in coronary artery disease. Watermelon, garlic, olive oil, pomegranate, avocados, broccoli, almonds, turmeric, asparagus, salmon, all these are beneficial. They are called artery cleansing food. So go through these slides at your leisure time. These are all the materials which are worsening. So avoid using all this material. Avoid using all this material. But these are some of the material which are beneficial like garlic, then pepper, turmeric, green tea, etc. What is good beneficial? Another is good sleep, balanced diet, avoid saturated fatty acids, which is beneficial. In emergency department, maintain oxygen level, cardiac monitoring, pulse oximetry or continuous pulse oximetry, central venous pressure, maintain the central line. You can use nitrate diuretics, treat the underlying cause, fluid and sodium restriction, urine input output chart, prophylaxis for DVT, non-invasive ventilation can be useful in some of the condition, particularly a person who has got a severe hypoxia. Then CRT, ICD can be useful, implantable cardioverter defibrillators, particularly in a person who are more prone to develop a VTVF and cardiac arrhythmias, dangerous cardiac arrhythmias. It is very useful. A person with a abnormal RV and LV function, you can go for CRT, either atrial pacing or AV pacing, we call sequential pacing or AV pacing or dual pacing, or you can go for RV, LV and RA, that is triple chamber pacing, etc. You can have a mechanical cardiac supports like intra-aortic balloon pumps, counter pulsation. You can go for ECMO. You can go for even LVAD, that is left ventricular assisted device, and end stage heart transplant. These are all the things, flow charts which are there for different types of heart failure. This is for acute heart failure, analgesic sedations, diuretic vasodilators, then artificial ventilation or mechanical ventilation supports, CRT and ICD, etc., depending upon the clinical conditions. I'll go through one slide, which is this is how you approach in a person with suspected acute heart failure. This is same thing mentioned if a person has got immediate treatment, intermediate treatment, and this is long-term treatment. At your leisure time, you can go through. This is the latest, which was published in 2012 by ESC guidelines. So at your leisure time, you can go through. This is again the same what we have given before. What you do in a different stages: stage A, stage B, stage C, and stage D. This is according to ACC guidelines. In stage A, usually treatment for hypertension, diabetes, rigid control of hypertension, diabetes, coronary artery disease, etc. by using ACE inhibitor, beta blockers, statins, all those you should use, and stop alcohol, use of sodium, etc. Smoking should be avoided. Once a person goes into stage B, by and large, these people are having diastolic dysfunction and systolic dysfunction, but still they are asymptomatic. You can go for ACE inhibitor, beta blocker, diuretics, and try to manage. But once they go into stage C, now you will require ACE inhibitor, beta blocker, diuretics, and if not controlled, you can go for ARNI, and if still not controlled, you can go for ICD and CRT or revascularization therapy. And if there is a refractory variety, by and large they require cardiac transplant, palliative care like artificial supports, and person usually has got a poor prognosis. This is a standard charts which is everyone is following now. That is stage A, stage B, stage C, and stage D. In stage C, it is further divided into preserved function and reduced function, and accordingly the treatment is given. At your leisure time, you can go through. If a person is in stage A, what are the things, what are the treatment, how you confirm the diagnosis, and what are the treatment part. At your leisure time, you can easily go through whatever I have mentioned in short is mentioned here in little bit in detail. This is the latest which has been put. If a person is having a reduced ejection fraction, that is stage 3 and 4. So if the ejection fraction is markedly reduced, after even ACE therapy, that is we call ACE inhibitors and beta blockers, full therapeutic dose is given, tolerable therapeutic dose is given, and still symptomatic and LV ejection fraction is 35. If answer is no, no further action required. Means if the person is better, there are no symptoms, and LV ejection fraction has improved, you don't require any further treatment, maintain. But if symptomatic and LV ejection fraction is less than 35, still it is less than 35, then you can go for ARNI treatment. You have to add those particular drugs. And after that, if there is no improvement, still symptomatic, now you will have to go for ARNI with ACE inhibitor, think about CRT, and adding evaporating. If the heart rate is still more than 70, evaporating should be added. If the person has not got sinus rhythm and QRS is prolonged, more than 130 small square, 130 milliseconds we call, 130 milliseconds, then you might have to go for CRT. And even after that, still person is not responding. Now this is a resistant variety, and if it is a resistant variety, you might have to give the artificial supports from outside. You might add digoxin. You can use left ventricular assisted device, or you can have a counter pulsation. You can decide for surgical intervention, or you can go for the last part is heart transplant. So this is summary of nearly the entire congestive heart failure. So you can utilize this particular chart, which is the latest. This is in short which is being given. So if a person is in a having completely normal, no risk factors, no hypertension, non-diabetic, non-obese, etc., you don't require anything. But if a person is in a stage 1 who is asymptomatic and LV dysfunction is there, like diastolic dysfunction, then you can go for, or what we call, systolic dysfunction, you can go for ACE inhibitor. ACE inhibitor is the first choice. In stage 2, NYHA stage 2, symptomatic, along with ACE inhibitor, add diuretic. Or you can add even digoxin, but digoxin is not commonly now utilized. If is further symptomatic and he has gone to stage 3, now you can add diuretics. By and large, what we say that ACE inhibitor and diuretics, particularly loop diuretics, becomes very, very important. As far as the neurohormonal inhibitors is concerned, you can use beta blocker. So ACE inhibitor, beta blocker, diuretic becomes the first drug of choice. And in stage 4, inotropes like digoxin, or you can use vasopressor drugs like dobutamide, etc. And then you can go for assisted device, and last is heart transplant. Same thing mentioned, combination. First, stage A, reduce risk factors. You have to explain the person. As he goes to stage 2, you can go for rigid control of hypertension, diabetes, dyslipidemia. You can add ACE inhibitor and beta blocker. After adding ACE inhibitor, particularly selective ACE inhibitors, beta blockers, we call selective beta blockers. If still person does not improve, he goes to stage C, what we call is a structural disease and symptomatic, where full dose of ACE inhibitor and beta blocker should be given to all patients with dietary sodium restriction, diuretic, and digoxin should be added. Now, if a person is having bundle branch block, he is having abnormal function of LV and RV, you can go for CRT, or you can go for ICD. You can have even a surgical intervention like valvular surgery, valvuloplasty, valve replacement, revascularization. As soon as he goes to stage D, we call refractory. So revascularization, valvuloplasty, valvular surgery is usually preferred if a person goes to refractory stage. But some of the time this is done even in stage C once it is controlled, to prevent a person from going from stage C to stage D. Now you can add aldosterone antagonists like aldosterone, inotropes, and you can go for what we call as the artificial supports like ventricular assisted device, and last is heart transplant. Same thing shown in stage 1, stage 2, stage 3, stage 4, and now it is called step 5. And step 5 is usually for transplant, LVAD, those particular. Now this is the latest what has been given. So at your leisure time you can go through, depending upon the ejection fractions, heart failure stages, etc. what are the treatment which are being suggested. This is acute pulmonary edema, how you approach to a person with acute pulmonary edema, where loop diuretics become the first choice. Loop diuretics, oxygen, then ACE inhibitor, beta blocker, they are the first drug of choice. So you can go for all this detail. This is diastolic dysfunctions. This is on the ground of, we call as a LV or RV failure. The most common is what we call as a warm and wet, that is congested lung with little maintained peripheral circulation. And if a person is having hypovolemia, hypovolumic, where you will require fluid replacement, but it is accounting for only 5% of the cases, and 20% of the cases are cold and wet, means there is a pulmonary congestion with a shock stage where you will require inotropes and vasopressor drugs. These are all in what we call as a refractory heart failure. You require inotropes, you require mechanical supports like intra-aortic counterpulsation balloon, left ventricular assisted device. Now there is one another device which has come, is called Impella, and last is you can go for cardiac transplant or heart transplant. In stage 3 and 4 you can go for a valve repair, that is valvuloplasty, valve replacement, pacemaker, we call as CRT, ICD. You can go for revascularization procedures, mechanical assisted device like left ventricular assisted device or Impella. And last is heart transplant, stem transplant, reconstructive surgery. This is a reconstructive surgery. This is CABG what is being done. This is a valve which can be replaced. This is LVAD, etc. can be done. So these are all the different. This is counter pulsation balloons. This is artificial heart, or we call heart transplants. This is LVAD, left ventricular assisted device. This is revascularization procedure. This is CABG. This is PCI, angioplasty you can call. All these are different procedures. PCI, usually the word now utilizes PCI. This is CABG. This is valve repair and valve replacement therapy. This is reconstructive surgery. These are reconstructive surgery. This is pacemaker. We can call ICD and CRT. This is CRT. This is ICD. You can have a mechanical cardiac supports as in between prior to heart transplant. This I have already shown you a slide before. This is a counter pulsation. During a diastole, this inflates. During systole, this is deflated. You can go for even ECMO. These are mechanical support. This is LVAD. Now there are also for both biventricular assisted device are also available. This is Impella. This is wonderful, and that gives you a wonderful result, but very costly. These are enhanced external counter pulsation which are used on limbs, particularly in lower limbs. Stem cell grafts or stem cell therapy is yet not giving good results. These are different types of devices which has come in market. So there are a lot of newer research which are going on. These are heart transplants. This was previously being done but not effective, so it is outdated. That is cardiac constraints. What is more important is prevention. Rigid control of hypertension, rigid control of diabetes, sodium restriction, weight reduction, restriction of fluid intake, bed rest, prophylactic treatment for deep vein thrombosis, even for infective endocarditis, regular exercise, etc. will help you a lot. Stop smoking, stop alcohol, stop sodium, NSAID steroids should be avoided, reduce weight, regular exercise gives you a wonderful results. As such, complications, person from acute can go into a chronic congestive heart failure or resistant congestive heart failure, recurrent congestive heart failure. Because of chronic congestive heart failure, person develop congestive hepatomegaly and we call cardiac cirrhosis, ascites. Acute congestive heart failure can end up with an AKI. Chronic congestive heart failure can end up with a cardiorenal failure, or acute congestive heart failure can end up with an acute cardiorenal failure. Electrolyte imbalance because of use of loop diuretics, particularly sodium and potassium, hyponatremia, hypokalemia. And person from stage 1 can go into stage 4, we call as a end stage congestive heart failure or irreversible, or we use a word resistant congestive heart failure. Person can develop cardiac arrhythmias either because of electrolyte imbalance or because of congestive heart failure, LV thrombosis, thromboembolism, infective endocarditis, pulmonary embolism, pleural effusions, and invariably they succumb, that is death. So these are all the complications which you can come across: edema, ascites, pleural effusion, hepatomegaly, congestive hepatomegaly, cardiac cirrhosis, myocardial infarction, cardiogenic shock, cardiac arrhythmias, electrolyte imbalance, mesenteric insufficiency, protein enteropathy, respiratory arrest, and person can even die. Acute MI, sometimes it is quite common. Digoxin toxicity is also common. Now, initially we had palliative drugs, then we came across neurohormonal drugs like ACE inhibitors, beta blockers, then came ICD and beta blockers, then there was invention of CRT. Now we have got what we call as a MR receptor antagonist, ivabradine. Now we have got sensing devices, and recently we have got an invention of we call as a angiotensin receptor neprisilin inhibitors, ARNI, and with that the prognosis has improved. Now this is called as a stem cells of future paradigm. There are a lot of drugs, right from renalazine. These are we call the PDE, mainly utilized for pulmonary hypertension. Then beetroot, dobutamine. Then these are all for use for pulmonary hypertension, pacing, exercise, externite, sildenafil. These are all utilized: spironolactone, days diet, nifedipine, ivabradine, anakinra. All these are there. These are all multiple drugs. You might have in near future something else is also added in this. But because of loss of these drugs are available, prognosis has improved. But still, prevention is better than the end stage treatment. So I end my lecture here regarding the approach to congestive heart failure and management. You will come across good number of time in your everyday practice a person with a congestive heart failure. So this will be a very useful to you if you can clinically make out in which stage it is, whether it is acute, chronic, it is in stage 1, stage 2, stage 3, stage 4, or according to ACC, ABCD, and diastolic, systolic. You can decide regarding a treatment and you can give a better prognosis.